Hi, this is Brian Kim. I'm going to share with you this case of a patient with a dense white cataract. And you're going to see double chop, cross chop, mechanical fracturing, but I'm also going to do a stop and chop technique and use a terminal chop. Normally when you do stop and chop, you make a central groove and then you crack within the central groove. This is not really that efficient, especially if you have a very deep, dense cataract with a posterior plaque. And so a terminal chop means you're chopping from the periphery and you propagate that chop from one side all the way to the other. To me, this is the most effective way to perform stop and chop by doing this terminal chop technique. I'm using a corneal marker, which will help me to center and size my rhexis. And then I'm making my side part incisions, first on the right side and then the left side, making sure the incision is flat to the iris plane, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then some intracameral epinephrine. And this is some intracameral air and then some trypan blue. I try not to be too aggressive with the blue and paint the anterior capsule with the cannula like a paint roller effect. I'm injecting some dispersive viscoelastic to fill the chamber and remove all the bubbles and the trypan blue. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea. Using the cannula to control the eye, I enter. I push some more viscoelastic at the end. And this is the puncture style capsular rhexis. I'm using the forceps to puncture the center. Pull down, grab the right side of the tear to create a flap. Go around circumferentially. This was not an intumescent white cataract, it was just a white cataract, and so I felt confident doing the rhexis in standard fashion. So finish off the rhexis, burp some viscoelastic out. This is the capsular fornix hydrodissection technique. I place the cannula out under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress, and then you can see the lens spins nicely. In these white cataracts, the cortex and epinucleus is not very well adherent to the capsular bag. To irrigate the surface of the eye, adjust the sleeve, lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. I have the tip pointing up here, and I'm going to go ahead and do the stop and chop. I'm in sculpt mode. And of course, whenever you sculpt, you're going to use a lot of ultrasonic energy, but the hope is it's deep, therefore not close to the corneal endothelium and unlikely to cause any damage to the cornea. This is a pretty dense lens, so you can see as I'm trying to groove, the lens is kind of moving on me. So I place the chopper out under the rhexis edge to hold the lens as I sculpt deeper in the bag. So as I do this, I go ahead and try to chop it simultaneously as I was grooving. You can see that it does fracture the lens. Again, this is that terminal chop technique when you're placing the chopper out under the rhexis edge and you propagate the fracture from the periphery. So I went ahead and did that same maneuver on the other side, and now I have two separate pieces. I switched to quad mode, placed the chopper around the rhexis edge, and crushed the lens between the instruments, and then very carefully crushing the lens pieces with mechanical fracturing forces, and then emulsifying the lens pieces here. Place the chopper underneath the second quadrant there, hooking the lens and then crushing it between the instruments, using a little bit of vacuum to help position the lens pieces, crushing the lens pieces, and then emulsifying the lens pieces. You can see there's virtually no epinucleus or cortex. And so in these cases, you have to be very mindful. You don't want to accidentally grab the posterior capsule. And that's why mechanical fracturing is so advantageous. So I turned that second heminucleus in front of me, placed the chopper around the lens piece, pulling it centrally towards the phaco tip, which is deep in the bag, and it easily fractures that heminucleus. Getting the chopper around that third quadrant, placing the phaco tip deep, carefully pulling the chopper centrally, which bisects that third quadrant, using some vacuum to position the lens pieces, and then crushing the lens pieces with the instruments, and then emulsifying the lens pieces. Placing the chopper around that last quadrant, pulling it centrally towards the phaco tip, placing that phaco tip deep enough so that it's a fulcrum point so that it can effectively crush and bisect the lens piece. Separating those deep adhesions, grabbing that piece with a little vacuum, which allows me to bisect the lens with crushing forces, mechanical fracturing forces, and then emulsifying the lens pieces. People who don't do this technique don't really quite appreciate the nuances and the subtlety of mechanical fracturing. Because you're using your instruments to crush the lens pieces, it's so important to be able to position the instruments around the lens piece perfectly so that the lens piece doesn't tilt or move on you. And just being able to crush the lens pieces in that manner just takes some experience in doing it. And once you do it, you're like, okay, I get a feel for what this involves. When you're just using the phaco just to cut and emulsify the lens, it's really just press the pedal and let the machine do the work. But when you're doing mechanical fracturing techniques, it's quite different and it's a little bit more subtle. And again, you can't quite appreciate it unless you've actually done it yourself. But in my opinion, it's so much more powerful as far as from a safety and efficacy standpoint. You're able to crush the lens pieces very precisely without needing ultrasonic energy or vacuum. And this, to me, is very safe because you can very carefully and systematically disassemble a lens like this. So you take the chopper out, push PSS in, take the phaco tip out, I go in with the INA handpiece. You can see I was able to very carefully, systematically disassemble that very dense lens, and I wasn't really worried about anything bad happening. I wasn't worried about the posterior capsule, I wasn't worried about the zonules. I was able to just very carefully disassemble this very dense lens with a pretty thick posterior plate. You saw I removed those big epinuclear nuggets. I switched to polish mode and I'm polishing under the rexus edge of any cortex, as well as the lens epithelial cells under the rexus edge. Typically, these bags are quite clean in these dense white cataracts. I'm polishing on the posterior capsule surface as well. There's some fine adhesions there. So once I'm done with INA, I'm using the cannula to pulse the subincisional space to remove any potential retained cortical material, which there was none here. So I'm injecting some cohesive viscoelastic to fill the bag, and then I'm going to use a capsule sweep to polish under the rexus edge. First on the left side and then the right side. On these dense lenses, I tend to use a 3-piece lens, partly because I believe that there's some associated weak zonules in these situations, and so I like the stability of a 3-piece lens. So widen the incision. Turn the barrel bevel facing to the left. Deliver the leading haptic into the bag. As the optic is delivered, I rotate my wrist clockwise about 90 degrees so the optic comes out flat. Deliver the trailing haptic outside of the eye, and then dial the trailing haptic in the eye with the Maltzman. Go in with irrigation off, activate irrigation, go underneath the lens, removing the viscoelastic from within the bag. and then removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, you saw that I did double chop, cross chop. I started with a stop and chop technique. You could see how in those dense lenses and weak zonules, sometimes the lens is so dense that the phaco doesn't want to cut. And so I was able to use the chopper to hold the lens on the contralateral side to provide some counterforce as I'm able to sculpt a little bit deeper. I did that terminal chop technique again, instead of trying to crack in the center, which I think is less effective. I'm cracking from the periphery contra-incisionally. That causes a fracture point that can propagate all the way along the length of the lens. In my case, I did it and it went halfway through, and I rotated 180 degrees and did the same terminal chop maneuver on the other side. By doing it this way, you get a very clean and effective separation of the two heminuclei. And this bypasses the entire posterior plaque situation where you have those dense posterior adhesions. Even though I had to do quite a bit of sculpting, I'm still under double digits on the CDE, and the patient did very well. So I hope this was helpful to you, and I thank you for your attention.